The talk I presented at a meeting in Cairo was regarding something that us as surgeons think is very important. And it was called the Lucerne Toolbox, published this last year in Lancet Oncology, and is mainly about the ways we can have to go into a better surgery after neoadjuvant treatments. The purpose of this toolbox was related to the fact that although we know from the last overview that neoadjuvant and adjuvant therapy in breast cancer have the same overall survival, and with the best and newest neoadjuvant treatments, we have better responses and more patients with complete pathological responses, we still don't have this translation in better surgery. So we still have too many mastectomies after neoadjuvant treatment. So the purpose of this toolbox was to give clinicians, so all the multidisciplinary team, the tools to get to the best possible final outcomes. So more breast conservative surgeries, less axillary dissections, more directed radiotherapy, and the best possible outcomes to patients. To that, we have divided the toolbox into 6 work packages that are directed to different phases of treatment. So the first one at diagnosis, the second one before treatment, the third one during treatment, what we need to do, and the 4th and 5 after treatment, and the 6th, the one that is directed to evaluating results. So this has lots to do with all the team. So from diagnosis, with using the indicated exams like mammogram, MRI, ultrasound, marking the lesions before starting treatment, see the patients in multidisciplinary team before starting treatment, evaluating patients clinically and sometimes with imaging during treatment, have all the markings, the biological determinants that we need before starting treatment at pathology, and then evaluating response with the best imaging possible and deciding the surgical treatment for patients that in case of response should always be prevalent regarding breast conservation. Doing the axilla and marking the axilla when you have a complete response before surgery provides you a tool to have a downstage of the axillary treatment, meaning that you can have a targeted sentinel node dissection and without having the need to go for axillary lymph node dissection. So you are performing a better surgery for patients and you are performing a better surgery for all. And at the end, in work package 6, you have the benchmarking, the evaluating of response, and the evaluating of your unit. So I think this is possibly for us surgeons that treat patients that go through neoadjuvant treatment, one of the most needed papers that come out through the last years. So I advise you all to read. And I think it was a great thing to be able to transmit this information while in the conference in Cairo. Thank you.